Hello everyone, my name is Anureet and my topic of presentation is sore throat. Here we have 25-year-old male who comes to clinic complaining of sore throat. You will be given vital signs, blood pressure, temperature, respiratory rate, and heart rate. In the next 8 minutes, you have to take a focused history and perform a focused physical examination. After 8 minutes, the examiner will ask you post and counter questions for 3 minutes. Before entering the room, you will be given 2 minutes, and it is very important that you write down differential diagnosis on the piece of paper. Differential diagnosis for sore throat will be infectious and non-infectious. Infectious causes includes viral, bacterial, infectious mononucleosis, epiglottitis, respiratory syncytial virus, retropharyngeal abscess. Non-infectious causes includes allergic rhinitis, irritant exposure, and gastroesophageal reflux disease. So, in the topic of sore throat, it is you will be tested most importantly on streptococcal pharyngitis. So, you should remember this box by heart, and you have to write down this box before you enter the room. After 2 minutes, you'll hear a buzzer. You'll enter the room by knocking on the door. You'll greet the examiner and the patient. You'll hand over the sticker to the examiner. Introduce yourself to the patient by your name and designation. Confirm patient name and date of birth. You gain consent from patient before proceeding further for history taking and physical examination. For the focused history of sore throat, it is very important that you ask some questions which are only focused on the sore throat. So you ask when it first started, what's the onset of sore throat, for how long does it last, duration of sore throat, and what's the character of sore throat, any aggravating factors, what makes it worse, any food, any particular activity which is making it worse, any relieving factors such as any intake of any hot fluids which makes it feel better, followed by any systemic symptoms such as fever, malaise, and fatigue, any history of any respiratory distress symptoms such as patient is not able to talk because of any difficulty breathing at rest. Then you ask any red flags history such as any history of any splenectomy and whether the patient is immunized or not. In case you are suspecting epiglottitis, you should be asking any difficulty swallowing and any drooling. In case you are suspecting any retropharyngeal abscess, then you should be taking history of any hot potato voice, any neck swelling, any stiffness of neck. Then you should be asking post-medical and post-surgical history. In post-medical history, you should be asking whether there is any recurrent streptococcal throat history or any recurrent tonsillitis, any history of any tonsillectomy in the past, followed by any medications history, for example, any recent antibiotic use, immunizations, and any allergy to any medications. In case the patient is a pediatric patient, then we should be asking daycare history and social history. Then we ask the sexual history of the patient. We specifically ask whether there was any recent unprotected urogenital intercourse. Then we focus on associated systemic symptoms such as any headache, any shortness of breath, any productive cough, diarrhea, rash, such as scarlatiform rash in case of scarlet fever. Coming to the focused physical examination, it is very important to start the examination by commenting on the general appearance of the patient, whether the patient is sitting comfortably or whether the patient is uncomfortable, in distress, diaphoretic, dyspneic, or drooling, followed by commenting on the vital signs of the patient. Then we start the physical examination from head, neck, and throat. We inspect the oral cavity, pharynx, nasal mucous membranes for any redness, any petechiae, swelling, tonsil enlargement, exudates, airway patency, and hydration status, followed by inspecting the skin for any scalatiform rash in case we suspect the scarlet fever, followed by palpating the anterior and posterior cervical and submandibular lymph nodes. Then we examine bilateral tympanic membranes for any erythema, bulging, or discharge. Then coming to the cardiovascular examination, we auscultate for murmurs in case we suspect any rheumatic fever. Then we do respiratory examination. We auscultate for crackles, decreased air entry, wheezing, stridor, and agophony. We also percuss for splenomegaly. Remember, we are doing a focused physical examination, so it is very important to cover important physical examination systems. The station involves the post encounter questions. You will be asked questions about investigations and treatment. So, for investigations, if we are suspecting group A streptococcal pharyngitis, it is important to do throat culture, rapid streptococcal antigen test. If we are suspecting infectious mononucleosis, it is important to do monospot test for heterophile antibodies. And it is very important to do complete blood count with differential test as well. And then if we are suspecting epiglottitis or any retropharyngeal or peritonsillar abscess, then it is important to do retro C-spine X-ray. Into the treatment of the sore throat, it will be based on the etiology. If we suspect viral etiology, then we focus on supportive treatment. We give salt water goggles, increase the fluid intake, throat lozenges, analgesics, and antibiotics. If we suspect streptococcal throat, then the treatment will be based on MAC-ISAC score. If the score is less than 1, then we don't prescribe anything. If the score is between 2 to 3, we do the throat culture and we only prescribe antibiotics if it is positive. If the score is more than 4, we do throat culture and we also start empiric antibiotics. The medication used will be penicillin 300 milligrams per oral 3 times a day for 10 days. If patient is allergic to penicillin, then we give erythromycin. In case we have tonsillitis, then surgical treatment will be tonsillectomy if there are more than 7 episodes of tonsillitis per year, more than 5 episodes per 2 year, and more than 3 episodes per 3 year. We will be following up with the patient if there is no response to the medication in required time frame, and we will be referring to ENT in case we have suspicion of tonsillar, peritonsillar, retropharyngeal abscess, or epiglottitis. Here are my references, and thank you.